Hey everybody, it's Steven from Asian Boss. If you're sick of COVID-19 and all the lockdowns, or having to wear a mask that keeps fogging up my glasses like this, you're not alone. But with the virus spreading out of control in many parts of the world and surpassing 10 million cases in the US alone, we're running out of patience for a COVID vaccine. Just exactly when is it going to be ready? What would the distribution process look like? For some answers, we're back here at the International Vaccine Institute. If you remember, we visited IVI about 5 months ago to have a chat with Dr. Jerome Kim, Director General of IVI and one of the leading vaccine experts in the world. I'm sure Dr. Kim has a lot of updates to share, so let's go and hear what he has to say. Good to see you again.
Great to see you again. Always nice to chat.
It's been 5 months since we last spoke.
It's gone by very quickly.
Yeah. COVID-19 it's still here. Things are getting worse in many parts of the world, including in the US. So we're hoping that you can provide us with some updates.
I'm happy to try.
What have you been doing at your end?
So, IVI is continuing to work with companies to try and advance COVID-19 vaccine development as quickly as possible. There's Inovio, which is an American company, and we're in discussions with other companies as well to see if we can participate in some of the what we call phase 3 testing of different vaccines against COVID-19. So it's been very busy. We've been writing applications and talking to people to try and put things in order to really get something over the finish line as quickly as possible.
Just for people who may not know who you are, could you briefly introduce yourself?
So my name is Jerome Kim. I'm the Director General of the International Vaccine Institute, which discovers, develops, and delivers safe, effective, and affordable vaccines for global health. A retired military officer. The U.S. Army, which most people don't know, has developed a lot of vaccines. And I have worked on HIV vaccine development for most of my research career. My background then is really in vaccine development, but I've also run a number of different kinds of laboratories, one that looks at something called neutralizing antibody, that is proteins that bind to and inactivate the virus. I've run a cellular immunology laboratory and a sequencing laboratory. So I have a lot of expertise, but I'm not an expert necessarily in all of them.
How many years have you been doing this?
So I started doing research in HIV in 1987, but it wasn't necessarily on HIV vaccines. HIV vaccines started in 1991.
So fair to say you have many, many years of experience.
Few decades.
Few decades. That's comforting to know. I suppose for people who are still not kind of familiar with the distinction between a cure and vaccine, how would you describe the difference between the two?
Vaccines in general prevent infection, or actually more correctly, probably prevent disease. Preventing infection is also important. Not all vaccines do it. Many vaccines will just prevent the disease from manifesting itself fully. Cures, so drugs, can be used to treat infection. So once you have an infection, you can take a drug that will make the infection go away more quickly, improve the outcome. And for COVID-19, we are still in the process of developing effective, safe, and affordable treatments that will allow the disease to go away more quickly. So for instance, people are using a very old drug called dexamethasone, which appears to decrease some of the body's overly exuberant responses to the virus. President Trump got dexamethasone. There's a drug that was approved by the FDA called remdesivir, which appears to have a direct antiviral effect, although people dispute whether its effect is as great as we had hoped initially. There are other drugs that are in the pipeline, but none have really kind of moved to the front yet. I mean, to the front in the sense that this is clearly going to be a silver bullet that really does a great job at getting rid of the disease. Nothing analogous to the drugs that we have for HIV, where we went from basically what was a disease that was nearly untreatable to 10 years later having drugs that effectively reduce the level of that viral growth in the body to zero. We don't have anything like that yet for COVID, but we've only actually known about COVID for 10 months, which is really amazing.
Because President Trump got this like a cocktail of treatment, people seem to conflate the two between whether that was a vaccine or a treatment. That's not a vaccine, right?
Correct. So what the president got when he came down with COVID-19 infection was a mixture of a variety of different things. He got some things like vitamin D, which are not necessarily shown to protect, but which we think may have a protective effect, probably not very harmful. He also got remdesivir, which is an antiviral, so something that may decrease the growth of the COVID-19 virus. He also received a special kind of cocktail of what we call monoclonal antibodies. So, your body makes antibodies against COVID if you acquire infection. Antibodies are proteins that are made by a particular cell of the immune system, and they're very specific. They recognize COVID-19, but they won't recognize the influenza virus, for instance. So if you had COVID-19 infection, you'll develop these infection-fighting proteins called antibodies. What we can do now in the laboratory is to develop very, very specific ones. So what your body does is it makes a lot of different antibodies. What we can do now in the laboratory is identify the ones that are the best, that appear to be the best at neutralizing, inactivating the virus, and we can grow them up in these giant steel vats. And companies in Korea, like Celltrion and Samsung Biologics, are actually among the world's leaders in the manufacture of these proteins. So actually, I think 50% of the world's monoclonal antibodies actually come from Korea.
Interesting. So
But
do people have access to that yet?
So no. So these monoclonal antibodies are available on a research basis only, so in clinical trials. The president got a special exemption, I think one of very few that were issued for the use of this vaccine, for the use of these monoclonal antibodies, because he was the president, or is the president of the United States. And they wanted to do everything possible, so they kind of threw the kitchen sink at it.
Let's look at the timetable for clinical trials and whatnot. Are we actually going to get a vaccine first, or are we going to get a treatment first?
So remdesivir has been approved. Whether and how effective it is at controlling virus growth is still a source of some debate. We probably will hear in November or December about at least one, maybe up to 3 of the different vaccines. And what we'll have is what we call interim analysis data. So when you do a big trial involving 30,000 or 60,000 people, you design the trial so that you're allowed to peek at the data. And this is actually done very strictly, and actually you take something called a penalty when you look, because the statisticians, the people who look at the numbers, really don't want you to peek too often, because it impairs the ability of the trial to really understand how the vaccine is, or if the vaccine is protecting. So the first of those interim analyses should become available this month or next month. And what it'll tell you is, based on a relatively small number of people, whether the vaccine is protecting against disease or infection and is safe. Now, on the basis of those data, a company could go to the Food and Drug Administration in the United States or to the EMA, the European Medicines Agency, to ask for emergency use, or conditional use, I think is what it's called in the European Union. And that will allow them to start giving the vaccine to more people. And depending on how it's structured, it could just be, you don't have to sign a consent to get the vaccine. You may just, you may actually get a piece of paper that explains to you that this vaccine is still experimental, we're still collecting data on it. If you become sick, you need to let people know that you received the vaccine so that we can monitor if the vaccine is working.
So is that considered like part of the trial still?
Emergency use would not be within the trial. The trials would continue
Right.
Until a more definitive answer is obtained. And a more definitive answer would be, the Food and Drug Administration, the WHO, have set very strict criteria for whether the vaccine is working. And so licensure in the United States will be based on having protective effect against infection of greater than 50% and having a lot of confidence that that is correct. That is actually the standard definition that the FDA uses for other vaccines. Whether or not they allow emergency use to proceed with less than that information is a possibility, and one that the FDA has openly spoken about. The one caveat that they put on it is that they wanted to have at least 2 months of follow-up information for safety on the average for everyone in the trial, which is very important because they're saying, okay, we understand there's a huge pressure to have a vaccine, especially one that's been shown to be effective on the one hand. On the other hand, our job, they're saying now, speaking as the FDA, they're saying our job is to make sure that it's not only effective, but that it's safe. So we want to have at least 2 months of safety information. Other organizations are doing something called a rolling review. So the EMA, the European equivalent of the FDA, is allowing companies to submit data as it becomes available, so that the EMA can now review data in real time. Other organizations are considering that. The Chinese have an FDA equivalent called the NMPA, and I think they're expecting to potentially see data from the companies in December. So Chinese, American, European, a lot of regulatory agencies are looking forward to seeing the first hint that a vaccine may be protecting or not.
I think the reason why people are so anxious, or even like the emergency use that you talk about, is because COVID cases are just like getting out of control, especially in the US. I mean, do you see it the same way?
Yeah, so the US is now in its third wave. I mean, there was the first wave, there was the wave over the summer, and now there's a wave that's even higher than the previous ones. In Korea, you've seen a different kind of, you've seen explosions, outbreaks, but the government in general has been able to suppress the outbreak back down to less than 100 cases usually, although they're still struggling with that now. But when you think about Korea with 99 local infections, I guess yesterday, with 51 million people.
That's pretty good.
That is pretty good. It's been difficult because I think, when governments released some of the requirements, people went out and they did what people normally do. But we have to continue to message, and we have to continue to emphasize that the things that protected you, the things that will keep countries out of lockdown, the things that will allow you to have economic freedoms, or the freedom to move around and do things, masks, distance, and hygiene. If that's the price of being able to do the things you want to do, I think in Korea, people accept that.
Mainly in Asian countries, people accept that.
Asian countries, maybe Australia, New Zealand, very few other countries. But, I think when you look at the UK, which is undergoing a series of lockdowns, or Italy, where certain regions are under lockdown now, you wonder what the trade-off is, and how countries are going to decide what the appropriate balance of, economic freedom or mandate around mask wearing, around hygiene and distance. And it's funny because even in Korea, you walk out on the street and people are wearing masks. The masks are important, distance is important, and it's you have to keep it in your mind all the time. Am I protecting myself?
That's why people are like looking for this vaccine to put an end to all this. And when we spoke 5 months ago, you said that things are progressing at a lightning speed. This is like the fastest that anybody's ever tried to develop a vaccine. Is this still the case?
So a vaccine from scratch, the annual flu vaccines are developed over the course of 6 months, 6 to 9 months. So, but that's a vaccine that we're familiar with, a vaccine for which the regulatory agencies accept lab tests. You don't actually have to do a trial in 30,000 people. But starting from scratch, we've moved at unprecedented speed, and if those vaccines are shown to be protective this month or next month, then that will be remarkable progress. And we've made remarkable progress in other things too. There's an international consortium led by WHO, Gavi, the Vaccine Alliance, and CEPI, which is trying to put together agreement on getting 2 billion doses of vaccine and distributing it to 190 countries around the world. 20% of their estimated supply will be provided by this thing called COVAX. We've never done that before. If we can do that, that would be a really remarkable triumph of internationalism over what we call vaccine nationalism, hopefully. These vaccines that were developed under what's called Operation Warp Speed, the US program, will be available for use in COVAX. Some of the companies have already committed, not all of them. China has joined COVAX. Right now, the two big standouts are the United States and Russia. So, if President-elect Biden is listening, he should join COVAX and join the international effort as well. Because, really, there are data now, modeling data, that would say that, if the high-income countries, and Korea is one of the high-income countries, but European countries, the United States, Japan, Australia, Canada, if they are to purchase the first 2 billion doses of vaccine as it becomes available, and don't make some attempt to distribute that vaccine fairly according to the needs of, global needs for COVID, the number of deaths from this pandemic will double.
Wow.
And bringing it under control will become less efficient. Because if you're only taking care of yourself, the epidemic can continue to rage in other countries.
Right.
And as soon as you open borders and people start to move again,
right.
It'll get reintroduced. And I think the other thing is, the vaccine is not going to be something that works immediately, right? I mean, it has to be made, it has to be distributed, we have to get people vaccinated, and it'll take some time. And as that is happening, there's still going to be large groups of people who have never been exposed to the virus, who are at risk, who could become infected and infect others. So masks, distance, and hygiene are going to be necessary even into the next year, as we're vaccinating, maybe 70 to 90% of the people in this world.
First of all, you said the number will double if we start pursuing this whole nationalistic approach. Why is the U.S. not part of that right now?
So I think it had to do with the U.S. walking out of the World Health Organization also. In fact, the U.S. government did provide money eventually to another organization called CEPI, the Coalition for Epidemic Preparedness Innovations, which Korea joined also, which is developing vaccines for outbreak diseases, including COVID-19. So other than the almost $12 billion the U.S. government has put in, CEPI provided almost $1.5 billion to kind of get vaccine development moving. And CEPI's funding is very interesting because it comes with a requirement for global access, which is very important when you think about all the other people in the world who need the vaccine. It also comes with a requirement that the vaccine be sold at a reasonable price. It comes down to, are we committed to a global solution for a problem that is transnational? We have to solve this problem. We have to solve it in a way where we address the problems that exist worldwide, because no single country will have a solution or be immune if we fail.
When it comes to the clinical trials, people probably watching, most of them are familiar that there are 3 stages, right? And where are we with that? I would imagine that if vaccine could be almost like something could be done by December or January, I would imagine that a lot of trials are in the stage 3 phase.
So there are 10 vaccines that are in phase 3, so the determination of efficacy and safety. There are 3 Chinese vaccines, one from a company called CanSino, one from a huge Chinese vaccine manufacturer called Sinopharm. Sinopharm makes 60 to 70% of the vaccines used in China. And then a smaller company named Sinovac. Sinopharm and Sinovac's vaccine are in clinical trials all over the world with tens of thousands of people. And I think we're expecting to see data from those trials in December also, if not sooner. So if you combine that with Moderna and Pfizer-BioNTech, which also could become available in December, and now Oxford AstraZeneca saying it may be available, able to look at data in December as well. I mean, you're looking at most of the companies being able to report something before the end of the year.
Wow.
Which is just remarkable. But I think that we get the idea that everything's done. But in fact, there are 47 vaccines in human clinical trials. There are some that haven't entered trials yet that look very promising. And whether the same group of vaccines that are the first to make it over the finish line now are the same ones we use 5 years from now or 4 years from now, we don't know.
What are the sample size like?
Sample sizes are, usually in the tens of thousands if it's a comparison of vaccine against placebo. It really depends on the number of infections. And so with COVID-19 sort of raging in Brazil and the United States and parts of Europe, the companies have picked a sample size around 30,000. So 15,000 people get vaccine, 15,000 get placebo or an inactive substance. And some of the trials are even larger. 60,000 is one of the high side estimates. Other companies are trying to get by with smaller sample sizes by targeting their vaccine against particular populations with very high infection rates. Although that can be a little bit, that can be a problem because, as you've seen, COVID can come and go. Within the course of a few months, an epidemic can be brought back under control by lockdowns.
Yeah.
So it's a slightly riskier strategy, but one that is faster potentially and cheaper. But again, different companies are taking different approaches to that question. The phase 3 trials are very important, and they give you really important information about protection. So the way you do a phase 3 trial with vaccine and placebo, you're really looking at protection of individuals. You give the vaccine to somebody, is he or she protected against infection or disease? The other question, though, and one that may be more important for countries, is, well, how do you protect society? Because, something that's designed to look specifically at protection of individuals may not actually give you enough information about how you're protecting the rest of society against disease. So if you're a country, you may not care that much that people get infected as long as you're not seeing hospitalizations and deaths.
Right.
And I think Dr. Fauci said this weekend, but it's something that people have known for a while, which is that right now the current vaccines are preventing disease. So they're looking at outcomes. They're looking at whether a person has a positive PCR test and has a symptom. But you know that 80% of people who have COVID are very minimally symptomatic or asymptomatic.
Yes.
So those people are not necessarily being looked at as a primary endpoint in these trials.
Right.
On the other hand, we know that it's disease that we're interested in. I mean, we want to prevent deaths. We want to prevent symptomatic illness. We want to keep the hospitals from filling up with COVID patients. And so to do that, you need a different kind of trial, something that's usually done after efficacy, but something that could be very important in helping determine this herd immunity. I mean, we talk about herd immunity all the time, but protection of other people in society who are not vaccinated, and what's the right level of vaccination that you need in order to achieve that. And we don't know that. And the trials that we're doing now won't necessarily tell us the answer.
That's interesting, because I actually thought that we would have been able to tell what that threshold is.
We can guess at what it is, but each vaccine may be different. And so, again, this is a separate set of clinical trials that are done once approval is given. We start to do what are called effectiveness trials. It's great to have a trial where you get assigned at random to vaccine or placebo, and a nurse calls you up a week before you're supposed to come in, and then a day before you're supposed to come in, and says, to remind you, don't miss your appointment. You have to come in and get vaccinated. But in the real world, no one's going to call you.
Right.
I mean, and so if you miss your vaccination, or if you're 2 months late, or if you skip it altogether, you may never get the correct vaccination regimen. So how is the vaccine going to work under real world conditions? The RNA vaccines have to be kept, one of them has to be kept at minus 70 degrees centigrade.
Minus 70 degrees Celsius.
Yep.
That's cold.
That's very cold. The refrigerator in your doctor's office doesn't keep that temperature. So we need a separate distribution system to be able to give that particular vaccine. Now, hopefully the company is working on a way to increase the temperature and is doing tests now to make sure that the temperature can be minus 20, which is still cold, or 2 to 8, which is refrigerator temperature. And it's something that would be difficult to transport in an airplane.
Well, that's right.
Because 747s don't necessarily have the capacity to have the freezers necessary to keep something at minus 70. And when you're talking about shipping hundreds of millions of doses, that's a lot of cold capacity.
There's a difference between what works in the laboratory setting versus what really works in real life. There's so many external circumstances or factors that are out of your control.
Yeah, right, and temperature and cold chain would be one of them, distribution would be another. We're really good at vaccinating kids. I mean, in the US, it's probably 80 to 85% of kids get almost all their vaccines, which is real tribute to American parents, actually. And around the world, for the typical vaccines, the ones that WHO recommends to be given in childhood, we're at about 80 to 85% also, which is great. So kids are fine, but how do you vaccinate teenagers? I mean, we really do have a hard time giving vaccines to teenagers, and then how do you vaccinate working adults? And how do we vaccinate the elderly? And when you think about who needs a COVID vaccine, it's everybody. And we don't routinely bring them in to care. So if you're a small country in sub-Saharan Africa or in South Asia, and you have certain number of healthcare staff who are delivering the vaccines to kids, and now all of a sudden you tell them, okay, time to start giving the vaccine to teenagers, adults, and the elderly. They're going to just do this they're not going to just do it in their spare time. It's going to take time away from everything else that they're doing.
Do you think it's too much of an outrage from, I suppose, freedom perspective to mandate some sort of a vaccine?
Having been in the Army and having received more than my share of vaccines, I can tell you that it is possible to mandate it and get really high rates of compliance, but not everyone's in the Army. So, what it may come down to is the protection of society. And I think countries and governments and insurance companies may actually, in the United States, may end up deciding, because if your healthcare costs, if you're a company, say you're Starbucks, and you're not vaccinating your employees, and a lot of your employees are coming down with COVID and getting sick and going into the hospital, your healthcare costs will be higher than a company that has been using vaccination to control that. So if you're the insurance company, what do? You go to them and say, you need to do something about this infection, or we're going to raise your premiums. And companies don't just raise premiums. They get a higher premium and then they pass it on to the employee. So there could be other mechanisms that apply later on, and particularly in societies where healthcare is not universal. But the good thing, I think, is that many countries around the world view this as very important, and they will engage the parts of the government that are good at convincing people that vaccination is critical. And it's funny because different countries are different. In Fiji, some colleagues who work in the Ministry of Health there was an outbreak of measles, actually in Samoa. And Fiji decided, well, we don't want measles to break out in Fiji also. And they reminded people that the population of Fiji, way back in the 19th century, had nearly been wiped out by measles. And they used that as a reminder. And they said, we got over 100%. I mean, we had people coming in who didn't need to be vaccinated, insisting that they wanted to get the vaccine. But it's communication. And it's convincing people that vaccines are safe and effective. And often we don't do that. We talk about vaccine hesitancy in the United States, but I mean, let's see, there are 26 or 27 individual shots that could be received for 14 different diseases, and 80 to 85% of American parents make sure their kids are vaccinated. They probably never seen mumps or measles because vaccines have done such a good job getting rid of them, yet they give them. So I think, we have to emphasize the safety, the efficacy, that the vaccines protect, and we have to be clear in the messaging. You can't have the CDC saying everyone should get vaccinated and someone else saying, no, don't get vaccinated, it's dangerous, or I wouldn't vaccinate myself. I mean, the messages from governments have to be clear and consistent, the way they are in Korea. I mean, around masks, around distance, around hygiene, and when they're about to make changes, they let you know, and then they reinforce the message time and time and time again.
I guess governments can try to do that around the world. As far as Korea, yes, we are getting a very consistent message, and I don't think anybody's really dumb enough to question the efficacy of vaccine. But there are so many, let's look at the United States, right? There are media organizations, there are all these conspiracy theorists. They have their own social media platform. This type of misinformation or disinformation, I don't see that stopping.
In fact, it won't stop. But so if you look at the numbers, probably 75 to 80% of people will take a vaccine if it's safe and effective. There's about another 10% or so of people who are undecided. We need to get them. And we have to convince them with facts and information, and there has to be consistent messaging. We have to be absolutely sure that the vaccines are, we have to be convinced that the vaccines are safe and effective. I mean, that is going to be a really important part of this. And then we have to get out there, and we are going to, the government, as well as other organizations, are going to have to convince people that this is something that we, as a nation, I guess, would need to do in order to get back to some semblance of normality.
What I'm curious about is that once you get this one shot of a vaccine, it could be one out of these 10 vaccines we have potentially coming up, will once be enough?
So all but one of the vaccines use 2 doses. And with the other thing that we don't know, and we won't know from the short-term data that comes out during November, December, January, is how long that effect will last. So, often vaccines require a booster. There's a suspicion that the coronavirus vaccines in general will require a booster. But we don't know that yet because we don't know the data on how long the immune responses, the protective responses that are generated by a vaccine, we don't know how long those will last. We hope that they last at least a year. And that'll allow us then to do booster vaccinations. The thing is that we don't know. So say there's the Pfizer vaccine looks like it's working and the AstraZeneca vaccine. Can you mix vaccines? So if you get the Pfizer vaccine originally, can you get a booster with the AstraZeneca vaccine? Some of the second wave of vaccines, that would include the Novavax vaccine, actually, which may come out soon, the Sanofi vaccine, some of the vaccines being looked at in Korea, may actually be better at generating very high levels of the protective antibody. Because they're a different kind of vaccine. We call them protein vaccines. And the protein vaccines generate much higher levels, and we can give those proteins with something called an adjuvant, something that boosts the body's response to the vaccine. And that may actually be able to get you 2 years or 3 years. And if it's given at the right time, a booster could last for a very long time. And again, we don't know the answers to that. So one of the things that we need to do the day after efficacy is figure out, did we really optimize the dose and the schedule? And what other things can we do in order to do that? Can we decrease the dose? Can we spread the dose out a little bit? What else can we do in order to maximize the performance of the vaccines that we have? And then what other vaccines are available that may allow us to be even better, to reduce the number of doses to 1, to switch from a boost every year to boost every 3 years. So those are really important questions for the day after.
You're basically saying that there's almost like a consensus that we'll definitely need a booster for sure?
There's a suspicion. I don't think you could call it a consensus. But people have been very concerned that protective responses against coronaviruses don't tend to last very long in nature. And whether or not the vaccines will give us better responses, we don't know.
Why in nature? Why does that happen?
It has to do with the different viruses and the kinds of protective responses that they induce. Sometimes when a virus infects somebody, or a bacterium for that matter, it does things to the body to trick it. HIV would be the classic example. HIV tricks the body in multiple different ways to weaken the body's defensive responses. So sometimes by certain features or qualities of the virus will cause the body's immune response to be less than optimal. And I think coronaviruses have evolved to develop very low levels of protective responses after infection in general. So if you look at the 80% of people who are asymptomatic or mildly symptomatic, it looks like their antibody levels, the levels of protective proteins, appear to be relatively low and appear to drop off fairly quickly. Although there's been some dispute recently about whether the killer cells or other parts of the body's defense system are still around, it may not be enough to protect you against a second infection. So, there have been a number of cases now around the world of very well documented second infections. It doesn't happen that frequently, and we don't know what level of protective response is needed in order to prevent that second infection. We're hoping that the vaccines will be at that level for a long period of time, but we don't know. So there are still another question for the day after efficacy is, what correlates with protection? How high does it have to be? How long does it last? And can we generate it with a vaccine or a combination of vaccines?
I guess it comes down now to two things. How much is it going to cost? And when are people going to actually get this thing?
Yeah, so cost is complicated. And just to give you an idea here, if we took the pneumonia vaccine made by Pfizer, they sell that to the Gavi for $3.05 a dose.
So for people who don't know what Gavi is, could you just...
Gavi is a vaccine alliance. So they're an organization that receives funding from countries and philanthropic organizations around the world, and they buy vaccine for poorer countries, what we call Gavi eligible countries. So vaccines that would be otherwise inaccessible because of cost are provided to countries around the world through donors. And it's been remarkable.
So it's a non-profit organization.
It is a non-profit organization dedicated to delivering vaccines to countries around the world. Now the countries have to promise that they will give the vaccine. So that's the onus is on the country, and they're responsible for putting in place the cold chain, the delivery, the healthcare workers. They have to do that part, but Gavi will give them the vaccine either for nothing or at very low cost. If you look at the Gavi price, $3.05 a dose for the pneumonia vaccine. In the United States, it's $200 a dose. Well, between $70 and $200 a dose for exactly the same vaccine. So the pricing depends on a lot of things. They go from a low of $1.37 to $70 a dose. The cheapest vaccine that people have talked about is one from Bharat, which is an Indian company. It's what we call whole inactivated virus. So they just grew the virus up and killed it, and they mix it up with something called an adjuvant, and that's what they're using to vaccinate. The most expensive vaccine, at $70 a dose, is also whole inactivated vaccine, made by a Chinese company, Sinopharm. Now, whether that's Sinopharm's final price, or whether it's the price now because it's only available on emergency use, no one knows. The thinking is that whole inactivated vaccines tend to be less expensive, so it's probably closer to Bharat's estimate, ultimately, but we don't actually have the data. Moderna's vaccine is going to be around $35 a dose. It could be slightly higher depending on how large the bigger the purchase, the lower the cost. So it's hard to say. And many countries will provide it free. For instance, in the UK, right? They have a National Health Service. They provide the vaccines free. Vaccines that are required under the National Immunization Program in Korea are provided free of charge. COVAX, so this mechanism that Gavi, CEPI, and the World Health Organization put together, they're buying 2 billion doses. I mean, not necessarily all of the same vaccine, but that allows them to make a deal on price, hopefully.
And in terms of timeline, when is it likely that we can actually get a shot, basically?
Countries like the United States, which have put $12 billion, actually, if you look at the cost of Operation Warp Speed, it's $18 billion. And they've secured over 2 billion doses of vaccine. Now, the United States has 330 million people, so if they get 2 doses each, that's 660 million doses. But they have 2 billion doses pre-ordered. And a number of those doses, several hundred million doses, are actually in the process of being made now. So that theoretically, once a vaccine is announced to be safe and effective, they may actually have millions of doses available for immediate use. Dr. Fauci, who is known to be, correct much of the time, has said, don't count on widespread availability until the middle of next year. And the CDC, US CDC, has warned the same thing. Now, this is in the United States, which has put a huge amount of money into pre-ordered vaccine. What about other countries? So, it turns out that around the world, 8 billion doses have been pre-ordered. Not much of it is going to low and middle income countries. That's actually going to probably happen through COVAX. Most of it has been pre-ordered by high income countries. So the European Union has purchased 1.5 billion doses, the UK 400 million doses, Japan 300 million doses. I don't think that they're going to actually see all those doses. I think that a lot of these were pre-orders in order to secure a certain level of vaccine if the vaccine is shown to be safe and effective. But again, COVAX has to compete against these global players from high-income countries that, basically have the money available to make pre-orders. But let's hope middle of next year, we'll start to see enough vaccine to be able to really realistically vaccinate many people.
So we still have to wait around at least another 6 to 7 months.
Possibly. And I think it's important to recognize that, the day after efficacy, we're still, I'm going to still put my mask on and distance and do the hand hygiene thing. Because, if you imagine that it's going to take maybe till 2023 or 2024 to have enough doses to vaccinate the entire world, there's still going to be risk out there. And, again, the vaccines do hopefully will be shown to be safe and protective. But we don't know if you get vaccinated and you go out and, to a bar surrounded by people who have COVID-19 infection, whether the vaccine won't just be overwhelmed. And we do know that happens.
That could happen.
It could still happen. So even after you're vaccinated, you should protect yourself. So there's one of the examples of a person who was reinfected may have been exactly that. He was infected, He recovered, and then he wasn't following any wasn't protecting himself. He went out and he got a second infection, and actually the second infection was worse. Now, thankfully, he didn't die. Immune responses are protective, but it's not absolute protection. And so there's still a reason to protect yourself against infection. The other part, which it's harder to explain, is that if you are vaccinated and you get infected, you may still be excreting virus. So, other people around you, the other reason to wear the mask is to protect others for the same reason that you wear a mask now.
I thought the whole point of getting a vaccine is so that people can stop wearing masks and then don't have to socially distance. Mm-hmm. But this is just...
At least initially, until we reach a level of protection in society where when there are outbreaks that they're going to be self-contained, and where the people who are most vulnerable, say the elderly, are protected against infection, and people who have underlying conditions or people whose jobs bring them into contact with sick people. And it's not necessarily, it's clearly healthcare workers, but think about teachers. Children have a special capacity to be able to spread coronavirus amongst themselves and then to the people who are teaching them. People who work in places where they see a lot of, where they meet the public frequently, like people who work in supermarkets or people who are doing deliveries or first responders, policemen, firemen. So I think we are still going to need to protect ourselves until we've reached that level of protection where society feels that it's safe.
What percentage of the population would have to be vaccinated?
We've been saying 60 to 70%, but really that's something that should be determined in these, in what we call the effectiveness trials, and the trials that are designed to look at the protection of society against infection. The vaccines are going to be useful. It's going to be much better than not having one. But remember that the vaccines are going to be a part of a comprehensive program of prevention, at least initially, until we can determine that we're at the right level of protection in society.
Could it also be possible that the virus will kind of evolve and mutate?
Yes, that's always a risk. The most recent emergence of this virus in minks emphasizes the problem that it's not only humans, but this going back and forth from whatever it was that infected the first human, maybe bat to something to human, then human to human, then human to mink, mink to human.
When did this happen?
So this is something that's been reported in the last week or so, but it's presumably been going on for a month or so before that because they've accumulated now, I think, 200 cases.
Wow, where is this?
In Denmark, and I think part of the Netherlands as well. And one of the clusters, it's called cluster 5 of these viruses, appear to be less sensitive to some of the protective antibody. So again, we don't know if this will be a bigger problem, if it's going to spread, if that virus is capable of spreading as easily as the regular virus. And we don't know that the vaccines at this point protect. I'm sure those studies are going to be done very quickly.
So I guess it's not all just this magic bullet solution that we were all hoping for.
So the day after efficacy, we're going to wake up and put on our mask.
Yes.
And hopefully at some point in the next few months we can be vaccinated, and that will give us an additional level of safety. And then everyone will have to make, governments and people will have to make risk assessments.
I think, though, it is still very important to manage people's expectations. They will still be like, then what's the point of getting a vaccine, right? And people start becoming cynical, knowing that this is not that absolute 100% protection magic bullet that everybody was hoping for.
What if the vaccine is not 50%, but 80% protective and against disease? And that would potentially be very important. Yeah. Even at 50%, it could significantly impact health in the community. So, and I think I gave you this example before. Our oral cholera vaccine, so it's a vaccine against cholera. When you look in the randomized clinical trial that looks at individual effects, it's maybe 55 to 60% efficacy. And you'd say, that's a partially effective vaccine. But if you vaccinate a city, or even half a city, its effectiveness is 85% at preventing severe cholera. So it's going to be important to stay tuned, to be aware of what the actual protective effects are. And it is going to be very important to have a vaccine, and if it's available, for us to be able to take it. because it will speed the path to being able to open things, to being able to do things normally.
Let's touch upon the whole equitable access type thing. What are your concerns exactly when it comes to equitable access?
Yeah, so, you know, typically with a vaccine discovered in the United States or in Europe or in Korea or Japan, the vaccine gets taken up and used by populations, by children in high-income countries. And then eventually the vaccine is rolled out in lower-income countries. So if you take a vaccine against rotavirus, so rotavirus is an infection you get when you're little. And it causes diarrhea. And in the United States, it caused lots of kids to be hospitalized for dehydration from the diarrhea. An effective rotavirus vaccine was approved in the United States in 2007. By 2009, WHO had reviewed the information and also recommended it. By 2020 now, 11 years later, 60% of children around the world have not received all 3 doses of rotavirus vaccine.
Really?
And that's the way it normally is, right? It starts, we implement it in high-income countries, and we gradually, put it in the mechanism for Gavi to purchase large quantities, for it to be distributed around the world, and for countries now, not only will have the WHO recommendation, but then they have to make a decision to use the vaccine, to add it into the programs that are already overburdened by other vaccines. So it's a process.
But it's been 11 years.
11 years, yeah. And it's a highly effective vaccine for a disease that still probably kills between 100 and 200,000 children a year around the world. And we've made huge progress. I mean, if you look at the number of countries, it's over 90 now. Countries have put rotavirus vaccine on their programs, but they haven't been able to implement the program. And so hopefully with COVID-19, we will find a safe and effective vaccine. We'll get it made in significant quantity with equity now with COVAX. At least 20% of the doses will be handed out by the end of 2021, which will mean that the elderly can be vaccinated and people who are healthcare workers can be vaccinated. And then by then, I think the hope is that we have enough vaccine available so that COVAX is no longer necessary, that countries can gain access to low-cost, effective, and safe vaccines.
Can you imagine scenarios where this could be almost like weaponized politically?
Yeah, actually there was an article in Foreign Affairs about just this, about a country using COVID vaccines and loans and going to countries that are desperate for a solution and using it to gain future political leverage. I'm not sure how that works necessarily. The world has pushed COVAX forward, but still, COVAX is only 20% of the vaccine that a country needs. What about the other 80%? And if you can't get your vaccine through COVAX, if for some reason COVAX fails, then it's really going to be every country for itself. And in that situation, you have a lot of opportunity for a country with money and vaccine to be able to make deals with countries that are less fortunate. Now we're hoping that geopolitical piece doesn't come to play. But in order to make sure that it doesn't, COVAX needs to work. And it's still short of funding.
So what is IVI doing to hopefully address this situation? Or
we don't purchase vaccines and we don't manufacture vaccines. So all we can do is really work with companies to try and show that the vaccines are safe and effective as quickly as possible, to develop the optimal regimens, so the right dose, the right schedule, determine what the optimal boosting is, show that the vaccines are effective and generate herd protection, because these are all going to be really important as countries try to make a decision about whether to buy vaccine, how much of it to use, who gets vaccinated first, and when they can be sure that some of the restrictions can be lifted.
I guess 2020 has just been an extraordinary year, and it's almost over. And how would you reflect on this year when you look back?
I think it's been a bit humbling. With COVID-19, we are hit with a pandemic that we weren't expecting. We've developed vaccines very, very quickly, but it's spread around the world. So, tens of millions of people are infected. 1.2 or 1.3 million people have died. How much has COVID cost the world? 20 trillion? So when you think about the small investment in COVID vaccines against the entire cost of this pandemic, it pales by comparison. But getting countries to step up, and volunteer the funding in order to vaccinate the world has been more difficult. There's been a bit of a leadership vacuum. I mean, maybe the United States normally fills that, but in the absence of the United States, you have COVAX trying to do everything it can, the WHO, Gavi, CEPI, all working very hard. I mean, you can see China moving in to fill a vacuum. But, someone needs to challenge the world. Challenge the world to join COVAX, to make it work, to ensure that vaccine is going to reach the people who need it the most. And then we'll see. But that'll require leadership and a fair amount of focus on what's important, what's a priority, and how do we get people to do the right thing, countries to do the right thing.
What would be your message to, I don't know, just the public who are absolutely sick of all these lockdowns, the economic costs, people with, drug overdoses and depression and suicide, all these things that COVID-19 has brought, and the eventual lockdown has brought, and people are just waiting for some sort of a solution, right? And everybody's now looking at this thing as, okay, vaccine is the only way. Like, what do you say to these people?
It's hard to say have patience, but people are working as hard as they can to get a vaccine that is safe and effective. And when we have that vaccine, it's going to be really important that countries and that citizens of countries understand what the benefits and risks are, and that really, this is a pandemic that is worldwide, that is as we say, viruses know no borders. Well, this pandemic has really showed us how closely we are all at risk. I mean, until the pandemic is controlled everywhere, we're really not safe. And so we need to recommit to a global response to COVID-19. And hopefully this will serve as a model for future endeavors, future pandemic response. For people who are tired of the masks and are just waiting for vaccine solution, the honest truth is that it's going to be a year. It's going to be years, potentially, until we're all safe. And what relief we get will come in bits and pieces. Having the vaccine, being vaccinated, being able to go out and do things again, it will come not all at once. So we're going to have to get used to living with masks and distancing and doing things to protect other people and spreading the vaccine message. When we have a safe and effective vaccine, we need to let people know. We need to stop misinformation. We need to talk truthfully about what the risks and benefits are. We can't just be Pollyanna and say, well, everything will be fine. I mean, we have to be honest. And I always hope that honesty is going to be the way that we convince people that we're sincere, that we're not just saying, oh, you need to get it because we own stock in a vaccine company, but because it's actually something that will benefit all of us in the end.
Thanks for sharing that inconvenient truth, but it is important that we know the truth and understand the science behind it. I think it's important for people to listen to scientists like you and not politicians or
Well, I'm sorry if it got a little technical, but I have to say, people really enjoy these Asian boss interviews. I've gotten feedback from people like all over the world, thanks to you.
That's very humbling. I think it's just whatever we can do to help, right? So what do you guys need?
Actually, IVI is just about full now. I mean, programs have grown, and as we try to do a lot more things, we're going to be stretched. But I think countries like Finland, Sweden, Korea, India have been very supportive. Individual donors have been very supportive, and hopefully we'll be able to do something. But can I make one more thing?
Sure.
So we focused on COVID, and COVID is a really important problem because 1.2 million people have died around the world. But the other global health infectious diseases continue.
Yes.
You know, if it's rotavirus diarrhea, Group A strep kills 500,000 people a year, and there isn't much funding to do research on a vaccine that prevents what we call strep throat in the United States, or strep pharyngitis. There still are other diseases, and a lot of other programs that need to continue that have been put on hold because COVID-19 has forced the closure of healthcare facilities, because you don't want people necessarily coming in if they're going to expose themselves to greater risk.
Yeah.
And you don't want to do mass vaccination campaigns because of the risk, again, that the crowds may spread COVID-19. So it's a big problem, COVID-19. Let's not forget it. But there are other things that it's impacting.
I just can't thank you guys enough for everything you do. The world is a better place because of people like you. And so we just want to say thanks, and then hopefully we get to catch up again.
Thank you. And it's always been great speaking with you.